Hill. Are there any other apologies?
I got a message from Joe Rafferty this morning, Chair, to say he's coming from one meeting to another, but he'll join us as soon as he can. Thank you.
Thank you. Declarations of interest. Does anybody have any interest to declare? No? So we go to item number 3, which is the minutes of the last meeting, which was held on the 22nd of December, and they're on pages 1 to 3 of your agenda pack. First of all, could I ask, are there any accuracy issues? None raised, no. Any other matters arising board members wish to raise? No. Can we agree the minutes then, please? They agreed? Yeah. Thank you.
Agreed.
Item number 4 is question time, and I can advise that no questions have been submitted for this meeting today. So we go straight to item 5, which is the COVID-19 intelligence overview. The report is on pages 8 to 24, and it provides a summary to the board on the current epidemiology and the impact on mortality related to the COVID-19 pandemic. It also provides assurances of the monitoring arrangements in place to enable a system response to any changes. So if I could ask Matt if you can speak to this, please.
Thank you, Chair. This is the usual update we bring to the Health and Wellbeing Board. All the information's in the report. Just because of the nature of getting the papers together, some of the information, particularly in relation to the infection rates, is slightly out of date. So, Peter, if you're okay just to pop those 2 slides on screen, I'm just going to give the board a very quick update as to the latest position. So the first slide just shows the latest epidemic curve. Appreciate that the detail on here is quite hard to see. I think the report in the pack says the latest infection rate is around 160 per 100,000. Actually, where we are right now is our infection rate is down to 54 per 100,000, which of course is great news and a much reduced rate from our peak on the 8th of January of over 1,100 odd per 100,000. So much improved position since that peak. I'm not expecting our rates to reduce massively more over the last couple of days. It's only come down a little bit. So I think we'll be there or thereabouts 50 for the next week or so. And then obviously we need to see the impact of the reopening up of the city, reopening up the country through the roadmap and through the starting with the schools on community infection rates. If you just go on to the second slide, please, Peter. This is the infection rates by age group. It's the heat map, and again, don't worry about the detail too much, but the highest rates are in the slightly younger age groups of the 20 to 29 and 30 to 39 age groups. That's the middle bits. It's good to see the infection rates in the older age groups coming right the way down, and obviously that is high rates in the older age groups are particularly indicative of increased hospital and social care pressure. So it's good news that those rates have come right the way down the other side, but we still have, although we have overall lower and reducing rates, where we do have higher rates, it's in the younger age groups. Thank you, Peter. I'm just going to pick out a few other things from the report, if that's okay. So just to note the section on ethnicity, and we know, excuse me, I'll just get the relevant page and I'll refer to that for you. We know that this is on page 14. Thank you. We know that the work that's been done at a national level shows a relationship between ethnicity, BAME communities, and both infections and increased morbidity and mortality as a result of COVID infections. Particularly for us, we can see a strong link with deprivation, and we'll come on to that later on in the pack. So just to note that on page 14, in terms of deaths, GP registered deaths, 1,244, I believe, is the latest number that we've had. And in terms of life expectancy, which is the point I really want to draw people's attention to, if that's okay, which is on page 20 of the report, we can really now start to see the impact of COVID on our communities And the really bad news, unfortunately, is that life expectancy has seen a startling reduction over the last year, a reduction of 2.4 life years. And life expectancy is now back at the level it was reported at being in 2006. I presented this information to the CCG governing body yesterday, and there was a very good question posed about how long will it take for us to recover from this position. I think the first point to make is, with everything else being equal, life expectancy historically has increased at around a quarter of a year to a third of a year per year. So that means that this impact of 2.4 years could take 10 years to recover. But of course, as we know, all things aren't equal, because we know there will be an ongoing impact on our communities as a result of both COVID, but also long COVID and the recovery of our health and social care system. So we definitely have it's not a surprise to us, but we definitely have a big challenge around how we address the impact of COVID on life expectancy in the city. And there is analysis of that life expectancy change by ward on page 21, which shows the difference in those life expectancy impacts by electoral ward. And you can very clearly see that there are wards on the right hand side, Church Ward and Woolton Ward and Utree, that have been least impacted, and on the left hand side, wards like Princes Park, Shoebrook, Stonycroft, Central and Anfield and Fazakerley that have been much more impacted. So that again draws out the inequalities element of the impact of COVID on our communities. So not only is there a lot of work to do around recovery from COVID, there's a lot of work to do in particular communities, particularly around inequalities, particularly around deprivation, to recover from the COVID impact. Chair, I'll stop there, but I'm happy to take any questions. Thank you.
Thanks, Matt. Questions, anybody? Or comments, even if not a question, Richard?
Thank you.
Richard, your sound isn't very good. Can you get nearer to your mic, please, if possible?
Is that better?
A little better, yeah, thanks.
Right. I was really surprised to see for this figure that actually 3 improved their life expectancy, including Church. Is that because people are being far more careful and not dying of flu, things like that? Questions about the Kent variant. As I drove back home to come to this meeting, the announcer was saying that the Kent variant is now the predominant one in the UK. Is it the predominant one in Liverpool City region? And there was also a suggestion that the mortality rate from it is much higher, anything between a third and 100% higher, probably going to be about 66. The second question really is, when will we know about if there is a rise because of schools going back? Because that also means more parents mixing at school and in fact going back to work. I haven't seen for a long time any comparison of the core cities. So I think we're doing well. Are we doing better or worse than the Manchesters and the Birminghams of this world? And have we got any emerging evidence about the number of people affected with long COVID? Do we have a long COVID clinic in place? And what do we know about how that's affecting people here? I think it's very important. But people say, oh, not so many people are dying, that's okay. Well, that's good, but does that mean that more people are going to be suffering for the next 3 years from long COVID? So I don't know enough about long COVID, and I don't think was probably saying enough about it.
Thanks, Richard. Matt, what I'm going to do is take a few questions and then let you come back to them, because we have got quite a heavy agenda. I've got Paul, Jane, and then I've got David. So, Paul.
Thanks, Acting Mayor. Just to make a number of points. First of all, a big thank you to everybody in the city, without whose combined efforts we wouldn't have been able to see that reduction in the infection levels and the virus levels across the city. It's been a collective effort. Once again, we've shown that by acting together, we can deliver real positive outcomes to people. It's really important that we don't get complacent as a city and the communities. Just because the infection levels are coming down doesn't mean that people shouldn't be just as careful to make sure that they wash their hands, they keep the space, and that they take protection measures to protect themselves and the other members of their friends and family. It is a tragedy in reality that we've seen that COVID has disproportionately affected communities that are deprived or BAME communities, and the death rates reflect that. I want to pay tribute to the CCG and also our public health team who have shaped the response to ensure that we try and make sure that any barriers for those communities are overcome, and that we're working with them to increase first of all the amount of testing, but also the vaccine uptake in those communities as well. And I really call on anybody who's streaming this particular message, make sure that you take up any appointment that you're offered as soon as you can, and make sure you're registered with your GP and your contact details are up to date, because it will mainly be through your GP that you'll be contacted. Thank you, Chair.
Thanks, Paul. Jane?
Thanks, Mayor. Thanks for all of the work that public health have done, Matt, and right across the city as well. It's interesting, isn't it, that public health has now been proven to be, in case the government forgot, incredibly important, even though it's been cut to shreds in terms of funding. So thanks for keeping going through all of that. And also the issue about deprivation, I think there's still the issue about people not being able to afford to stay off work, that we've somehow got to address and push back to the government, because that's where we must have spent between 18 and 20 million now of our own funding out of the council's coffers to prop up people, to stop them going under, and to help them when they're struggling to make ends meet. And in terms of this should then obviously link up with the Marmot recommendations, which I know you know standing on your head, and the double whammy of austerity and COVID. I think that's got to be more recognised by government as well. And just one other bit. The Church of England has just come out with their Coming Home, Tackling the Housing Crisis report, which came out at the end of February. And it's really interesting. It's got very good endorsements from people like Shelter, Joseph Roundtree. Obviously, there's lots of overlaps here, but particularly around very poor housing, damp, asthma, underlying health conditions that are exacerbated by poor housing. So if we could pick that up as well. Thanks very much.
Thanks, Jane. Very good points. David?
Yeah, I'd like to second what Matt has said around inequality and what Jane followed up on with regard to the Marmot principles. Matt mentioned life expectancy increasing by 3 months a year. That was before 2010. So we know that life expectancy plateaued. You can see it in the graph on figure 10 in Matt's report. Life expectancy nationally had stopped increasing and was going backwards in poor areas pre-COVID. We've got a paper under review at the Lancet showing that the local government spending and cuts to local government spending were a major contribution to that stalling in life expectancy pre-COVID. And then the pandemic has been layered on top of that. I wanted to make just a specific point about one of the recommendations. What is it talks about targeting, and it's on page 23, targeting responses and control measures. But in the Marmot report, there's the focus on proportionate universalism, and I think the inequalities picture speaks to systemic issues, and we should talk about proportionate universal responses, proportionate to need, rather than targeted responses. Thanks very much.
Thanks, David. Really good point. I can't see any other hands up. Tony, you didn't want to come in there. Matt, if you want to come back to those points.
Yeah, I feel like it's a bit of a memory test there. I'm pleased I started writing down the questions, otherwise I'd struggle to remember them all. I'm going to try and do this in reverse order. First of all, David, you're absolutely right around the life expectancy. I forgot to say, when it was going well, life expectancy was increasing by about a quarter to a third of a year. You're absolutely right on that. And the point about life expectancy, and particularly female life expectancy, plateauing over the last couple of years is well made. And I totally agree with you around proportionate universalism. That that is something we are building into our response and recovery plans, but you're right nonetheless. Jane, on self-isolation, we have made several representations to governments about the need to adequately support people who are required to self-isolate. There's a mandatory and a discretionary grant available to local authorities. What I would say is we have a good offer in place locally for our citizens, and with helplines and with support for people to access if they are able to. So if people are advised to self-isolate, our strong advice is get in touch with the council and we'll support you in the best way we possibly can do. And then Richard, life expectancy relative impact. So we know that the biggest impact on life expectancy over the last year has been COVID, but of course it's not the only impact. People, I think around over 4,000 deaths in a year. So people die of many things, but the biggest impact in terms of excess mortality was through COVID. And of course, you're right that there have been people dying less of, or rather delayed from, other diseases as well. So I think this stuff will catch up over time. In particular, the flu season has been particularly quiet this year, but that doesn't necessarily mean next year will be the same. In fact, we may well end up having a more severe flu season next year as a result, because we will have less people with an immune response built in for the strain that's circulating at the time. So that's something we're mindful of now in relation to next winter. The Kent variant locally now makes up 98% of positive Liverpool cases for ones that are sequenced, so 98%, and so the vast majority, and that did in the same way as for the rest of the country, that increased quickly from making up a small proportion to making up a large proportion. That shows why variants under investigation and variants of concern are so important for us to keep an eye on. In relation to the mortality rate in relation to the Kent variant B117, I've equally seen that report. I still think it's emerging evidence, and I'm not clear that there's a definitive answer on that, but absolutely estimates that there is a 30 to 50% increased risk of mortality and morbidity as a result. Schools, we will start to see the impact a week to 10 days from Monday this week, but as with all things, it isn't just as simple as the schools open up. It's how people behave in general around the city with schools opening up. So it's what parents do, it's what staff do, it's what we all do as a community with the opening up of cities. And we've seen that when we have good weather weekends, our parks are particularly busy, and perhaps when the weather's worse, we have less busy as well. So it's a wait and see. Good point on core city analysis, and I can do some work on that and get that to you. Having looked at peak infection rates actually last night, I can tell you that the peak infection rates for all the core cities was on the 8th of January uniformly, and ours, Liverpool's, was the highest of all the core cities at that point. But right now we are towards the lower end of core city infection rates, so we are in a good position relative to other core cities. I'll get you that information. And the final question was on long COVID. We do have long COVID services in place in the city, but maybe Janet and Carol are better placed to respond to that one.
Thank you. Janet or Carol, do you want to come in on that? Janet, I can see you indicating.
Yeah. So long COVID services have actually been set up across Cheshire and Merseyside, but the service is being provided by the Royal Hospital, and so the referral is through the GPs. There is a range of steps that the GP needs to take before, and there are also some online rehabilitation services that are available to direct the patients to without necessarily going through the long COVID service. It only recently started, and I know that they've already got quite a long waiting time, as you'd expect, but that's because there will have been a backlog of a year's worth of cases. We're still kind of getting the data and seeing how that works, but the predominant symptoms seem to be kind of respiratory and psychological. The Liverpool Pulmonary Rehabilitation Service, the BREATHE programme, is supporting patients at home actually with recovery from long COVID, and going really well. I saw a presentation about that last week, and they're meeting an awful lot of people's needs. But it's an evolving illness. I don't think we know enough about it. It may not just be one particular illness, but a syndrome of them. So it's I think I would say just say watch this space. You know, it's evolving service.
Thanks, and I'm sure in future meetings we'll have updates on that as that research and data starts to emerge, that we can keep all updated. Sarah?
Yeah, as somebody who's had long COVID myself for nearly a year now, and very extreme at times, there's probably a little bit I can add to that. I'm very involved with all the long COVID support groups nationally, and I've been involved with the National Institute of Health Research on their rapid review of long COVID and on their long COVID funding call. So there's quite a lot of research emerging. There's more being commissioned recently. And the long COVID clinics are probably in their very early stages. Quite a few patients have contacted us to say they've had problems with referrals having bounced back because in the initial stages, GPs weren't always necessarily clear about the steps that had to be taken first. I've seen one person feeding back that it's made a big difference to them. Other people, it's still too early. I'd say across the board, most of the people with long COVID, it's been kind of fatigue issues are probably predominant after the initial months. For a lot of people, lung issues tend to clear maybe by about 3 to 6 months, but they still continue for some. Heart rate issues are quite considerable as well. So it does meet the pattern of quite a diverse range of symptoms for different people. And I think we'll only see in time, but Janet's right, there's going to be a big backlog of people who are wanting that service and whose expectations from that service are probably higher than the service is going to be able to deliver, given the resources available to it and the staffing levels.
Okay, thanks for that, Sarah. That's really useful. Thanks, everyone. I've not seen anyone else indicating. So if we move on then to item 6, which is the briefing on the Health and Care White Paper on pages 25 to 35 of your documents. This provides an overview of the recently published white paper on the proposed changes to health service planning, commissioning, service integration and governance. So first, can I invite Martin to speak to this, please?
Yeah, thank you, Chair. I'll just say a few words. I'm sure most people have read it and will already have their own views around it. I think it's just to say that the white paper really heralds a change in the national approach, which will also have local implications. It fundamentally is about promoting integrated care, but in particular, it's looking at changing the commissioning arrangements more fundamentally within the NHS in particular, and changing some of the guidance around how they operate and the infrastructure. What it will mean is that we will see the change in the relationship so that CCGs are no longer have the role that they currently have, and that CCGs locally would come together into one integrated care system. Largely that would be across Cheshire and Mersey, so the 9 local authority areas. There would be establishment of an integrated care system board with a partnership level of arrangement as well. The role of health and wellbeing boards would still remain within the governance, and we would see those changes come into play in April 2022. Where there's currently consultation going on around some of the infrastructure and arrangements and trying to understand what things will still be commissioned at a local level, because I think there is acceptance that many of those decisions still need to be made to reflect locality. So for us, the locality obviously would be Liverpool. The paper talks about health and social care, but it is relatively light and quiet in terms of what it says around some of the other elements. So in particular, public health and social care. We haven't yet had the green paper on the future funding of social care, and we still haven't had the confirmation of the funding grant for public health and what those arrangements would be in future. We'd see coming together of some of the national bodies, so where we've got NHSI, who looks at regulation, and NHSE, they would come together under NHS England as an overall banner. And as I said, that what we will see is a lot of consultation now around some of the governance arrangements, but some of that's already in play.
Thanks, Martin. I've got 3 people I've seen indicating so far: Richard, Paul, and then Tony. Want us to come in, Richard?
Thank you. I'm right up by the computer, so I hope you can hear me. Last week, we had the first meeting of the Ministerial Advisory Committee looking at the white paper and its transition to a bill. And I serve on it with a councillor from each of the other parties, and 6 chief executives to keep us in order. I thought I'd just feedback some of the impressions from that meeting, which are well replicated in the report. First is that this is a much better white paper and will lead to much better legislation, we think, than the 2019 bill, because the 2019 bill was solely about the health service, and it was health service reorganisation. And there has been a much clearer understanding now, perhaps caused by COVID and all the good things that local government have done, about the role of local authorities in this. And that's why there are 2 boards, effectively. The top one, as it were, will be an NHS board, but there will be some local government representation on that. But in some ways, more importantly for us, will be the partnership board, because the government, I think, really does understand things now, like the social determinants of health, in a way that they didn't before. Just a couple of other brief points. The first is there appears to be no threat now, as there was 15, 16 months ago, to take away public health as a service provided by local government. There is confusion about how it will work. For example, they're putting more money into obesity campaigns. They think they can commission STP-wide advertising, for example, and campaigns. But frankly, large parts of Cheshire have no relationship to either the media that serve us, and there's far more in common between places like Winsford, Bootle, and central Liverpool than there is between the first 2 of those and anywhere in Cheshire. So there's a lot to be worked out, but I do suspect that there's goodwill around. The other thing that's absolutely clear, was hammered in by every councillor, this is a meeting with Helen Whately, the Minister for Care, is this understanding of place and layering, which Tony Reeves talked about at our last meeting. I think there's an understanding that below what takes place at this huge Cheshire Merseyside level, there will be a series of initiatives that can only be taken either at council level or below it, or by a combination of councils, depending on the subject. So I think that now is the time for us to be extremely positive, not because I'm confident that we'll get everything we want, but the government is in much more of a listening mode than I've seen them for many years. But as Martin says, particularly for adult social care, unless they sort out the funding, the structure doesn't mean all that much. Thank you, Chair.
Thanks, Richard. Paul?
Thanks, Acting Mayor. The government may be in listening mode in some respects, but I would have to say the council did send out a clear message that we didn't want the Cheshire and Mersey footprint to be imposed on us, because we had a firm view that place, in other words, Liverpool and the North Mersey, that's Liverpool, Seddon and Knowsley, was a really good fit in terms of patient flows and in terms of system operation, and if it had to be on a wider footprint, there was some synergy on the city region, but as has been previously said, there are parts of East Cheshire that tend to look more towards Manchester. Nonetheless, we are faced with the footprint that we've been given for this health and care partnership. We the key issues that I would want to stress here are, first of all, we mustn't lose the emphasis on prevention, on public health, on community and primary care. Effectively, it is cheaper and better for our residents to keep people well than it is to patch them up when they get sick. and making sure that we invest in that area of activity must remain a key priority for us. Secondly, we want to keep as much of the commissioning down here on the City Council footprint or on that North Mersey footprint as at all possible. We understand the locality of our residents better than the old Strategic Health Authority footprint. We have, and really importantly, we have those soft skills and relationships which have been built up over many, many years, which have worked very well here locally during COVID and enabled us to respond very quickly and very flexibly. A couple of obvious examples, the NHS allowing us to engage in the mutual aid scheme for PPE very early on in the crisis was undoubtedly a combined effort that has saved lives, and building on those soft skills and those soft relationships and not losing them under the structural change is really important. And finally, I think at least this white paper nods towards social care, but ultimately, unless it is properly funded, the reality is that our social care system remains creaking at best at the moment. It must be properly funded. And personally, I wish that the Chancellor had focused and prioritised the proper resourcing of social care in the last budget, because the failure to do so just continues to store up the problems in the system. I'll let Jane deal with the surprising comment that the government has got the idea about social determinants of health. Her shock and awe expression mirrored my own, but Jane will express it more eloquently than I.
Go on, Jane, I'll bring you in now then before Tony, before you...
Or I might just lose the plot, Mayor.
You might. And don't play poker, whatever you do.
So I totally disagree with Councillor Ken. I agree with him on some things, but not on that. If they really understood what they were talking about, why on earth would they refuse to admit that we needed to ensure that people should have a healthy standard of living, as in one of the crucial Marmot's recommendations? I think I'm picking up what Paul said before. I think it's absolutely crucial that we really push back in terms of making sure that the government somehow push them into a corner, or whatever, get them to give us enough money to be able to give out good contracts to people to ensure that at least the carers have real living wage, decent terms and conditions, decent living hours, because that's the bedrock of some of this. And the pressure that the carers are under in the system is extreme. And we all recognise that in Liverpool. For some reason, the government work in silos in their brains, and they really need to connect. Perhaps I'll leave it at that, Mayor.
Thank you. Tony?
Yeah, I won't get into the politics about what the government understand or don't understand here, but there's one thing here that is absolutely clear for me, and I know from discussions with NHS colleagues and at the ICP meeting, we'll touch on this a bit later, we recognise that when you look across the footprint like Cheshire and Merseyside, it is in no way homogenous, that landscape. With the levels of deprivation we've got, particularly in North Liverpool and in other parts of our city, if we don't get the place-based approach right, it's going to exacerbate the challenges around health inequality, etc., that we're facing, and the life expectancy data, the COVID data, has brought very sharply into focus once again earlier on. I think we believe really, really strongly that this is not a time to wait for permission to act and wait and see what shakes down at a Cheshire and Merseyside level, but for us to move at pace and carve out what that place-based approach looks like. And it isn't about what the institutions do together, it's what we do with our communities in our neighbourhoods that is really going to make, and primary care playing an absolutely key role in that as well, that is really, really important. And then the final thing I'd say on this, because I know we could all debate this for hours, I'm very conscious of time, is it's the wider city plan issues as well that we can bring to bear at a neighbourhood level. Because somebody's touched on, Richard touched on determinants, and I'm not going to get into the discussion about that, but what is absolutely clear, when you look at the stalling of life expectancy or reversing of life expectancy, there's a whole load of poor health that sits beneath that that drives that falling life expectancy, and that poor health is affecting productivity in our economy, and it is in itself affecting deprivation, and deprivation then affects that. And if we're going to lift our communities out of poverty and improve health outcomes and empower people to take control of their own lives, we need that systemic approach, and we can only do that at that neighbourhood level. And this is where we've absolutely got to get the place-based stuff right. So I was going to say this later, Wendy, but I just think, given this bit of the agenda, I couldn't really wait. With your agreement as a health and wellbeing board at ICP level, we will really move forward with developing proposals to work on with you and debate with you around what that place-based model looks like, rather than waiting to see what drops off the table at the Cheshire and Mersey footprint. Completely agree with Councillor Brandt's analysis. When you look at the patient flow data, if we were designing this ourselves, we would be talking about North Mersey, and because there's much clear, and creates a much more coherent policy focus in terms of the issues and the underlying data for the communities in North Mersey. Final thing is, with geographies for things like this, they come and go. This is about systemic change over the long term, and that's why the place-based stuff, Liverpool was always going to be a relevant geography for what we're doing. Getting the place-based stuff right, getting that systemic action in place, and then collectively with our communities pursuing that relentlessly over the years ahead is the thing that will really make a difference. If we're going to get beyond having informed conversations about the problems our communities are facing and really seeing progress in terms of those outcomes. And I think that's the challenge for all of us now.
Thanks. Sarah?
Yeah, I completely agree with all of that and with the comments that Councillor Brand made. From a patient and public point of view, the geography of Cheshire and Merseyside makes no sense at all. Yes, there's commonalities with people who are near neighbours in North Mersey, but we have no commonality. I meet regularly with my other Healthwatch colleagues, and with Healthwatch Cheshire, the issues that they get, the services it talks about, there is very little common ground. And it's very hard to see how Cheshire Mersey footprint can have any relevance to local people and their needs. And we know about the scale of the challenges we've got in Liverpool that we had in terms of inequality before COVID. Now, as we know, our life expectancy is dropping, our inequalities are increasing. It feels that the only people who are going to care enough about our Liverpool geography and our Liverpool health and wellbeing is local partners. And yes, things can happen on a wider footprint as well. But I completely agree, we need to face the local challenges within Liverpool.
You're on mute. Yeah.
How rude is
apologise,
the chief exec muted me? What I was going to say is most of those were comments, Martin, rather than particular questions. I don't know whether there's anything you wish to come back on.
No, I think you're right, Chair. I think it's a series of comments. I think there was a fairly good commonality in those comments, and I think as Tony's outlined, it's about us getting up our plan as how we're going to take this forward.
Yeah, particularly on the place-based stuff, I think that's seems to be what everyone's saying. So the recommendation is to note the proposals and implications for the board and wider system. Is that agreed?
Wendy, could I just suggest in noting them, you also ask the ICP to come back with proposals around the place-based approach.
Is that rather than do that bit of the...
Yeah, I mean, because ICP is just an update later. Once we've got recommendations here, I'm wondering if the board would like to resolve that ICP bring back firm proposals.
Definitely.
At the earliest opportunity around the place-based
I can see anyone
options.
nodding, so I don't think that's an issue.
Thanks.
Thanks, Richard. Thanks, everybody. If we move on to item 7 then, which is the Liverpool Safeguarding Children Partnership Annual Report on pages 36 to 79, which is an overview of the partnership, which brings together organisations in Liverpool to safeguard and promote the welfare of our children, as well as updating on the multi-agency safeguarding arrangements. Steve, do you want to address the board on this?
Thank you, Chair. Yes, this is the first report since we've changed our safeguarding arrangements in terms of governance and the safeguarding board. The chair for the 1920 period, which is the period this report covers, is actually Jane Lunt from the CCG, but Jane sadly is on leave this week, so she's asked me to present the report, and I am actually now currently the chair of the safeguarding board. So from the 1st of April, we changed to the new master arrangements, which effectively meant we now have a very small board made up of the reps from the key agencies, and we don't have an independent chair. One of the partners chairs the group, but what we have done is commission separately an independent person to do some scrutiny, and the outcome of that work will appear in next year's annual report. So just some of the headlines then. So we have the main board, we have the forum, which is the wider partnership with a large membership on that group. We have 3 subgroups that focus on Liverpool's business, but we are increasingly making links to some of the Merseyside-wide children's safeguarding forums as well. In terms of the focus for the Safeguarding Forum, they've been looking at teenagers, neglect and domestic abuse, and certainly the thematic priorities for the Safeguarding Board during this year, the report refers to, was focused on teenagers, neglect, domestic abuse, and also child exploitation. Some of the detail on the progress and the priorities is covered in pages 12 to 21 of the report. In terms of moving forward, the board has identified a few areas of focus, reviewing how we do scrutiny and review, ensuring we have the child's voice loud and clear. And you'll see in your papers there's a very short 1-page version of the annual report that the young advisors have produced. And again, it's been a really positive year for our young advisors who've done some excellent work for the board. And there's also a focus on multi-agency training. That's one of the main responsibilities of the safeguarding board, and we've done some excellent training this year and had great engagement from partners. I wasn't going to say a great deal. Obviously there's a lot of detail in the report around the priorities and the work of the board and all the partners who've been very supportive. Obviously, I think I'd characterise the work of the partnership as being very positive and really driving forward improvements around safeguarding practice, but we can't really hide from the fact that some of the risks our young people and indeed their families are dealing with have got worse in the last year, partly linked to COVID, partly linked to other things as well. And there's a separate item on the agenda today that I was going to talk briefly about how some of those risks are materialising. Thank you, Chair.
Thanks, Steve. Questions, Jane?
Thanks, Wendy. Just one on, I think it's page 44 in the report in our papers, and I don't know what page it is in the actual report, 9. Under the scrutiny, audit and review section C, where we've got neglect. I know it's a stock record with me, but could we just double check the neglect strategy again, where it's linking up high deprivation stroke child poverty, because we need to tease that out and be very specific what we mean about that. Where we're meaning someone's neglecting to put money towards food for a child who has money, that's completely different from they have no money to put towards the food to give to the family, and they're actually not eating themselves, for example, or keeping the house warm, and also the link up with housing on that one. I wonder if later on as well we could look at the predicted outcomes around the new theme that you want to run through at the moment about embedding trauma-informed social work practice, because I think that would make a big difference. And that's already happening, obviously, but it would be good to see how that makes a difference, and under what headings those associated action plans, where that links up, and it would probably be cross action plan, and then also the link with needing, or perhaps we have, but needing really good training for specialisms. So we have social workers that have specialisms, particularly around autism ASD, because that also has a huge impact on a lot of things. Okay, thanks very much.
Thanks, Jane. David?
Hi, Steve. Thanks for that. I thought that the report would be improved by addition of longitudinal data, because I thought the kind of elephant in the room in the report is on page 45 of the pack. What we're worried about, the continued rise of children in care in Liverpool. What does this say about the effectiveness of partnership working, and how, like a public health report, having some longitudinal data so we can see what's going on would really help. As you know, we're involved in various research projects looking at the rise in inequalities in children being taken into care nationally and the drivers of that, which I'd be happy to talk about at some point. But briefly, we know that structural factors, the factors that we've been talking about in relation to all these other things, are also the factors that increase risk of children being taken into care. Particularly in our research, we're seeing a syndemic of poverty and mental ill health in families that really impacts children's risk of adverse outcomes.
Thanks, David. Any other comments? No, Steve, do you want to come back on those couple of points?
Yeah, thank you, Jane and David. Really helpful points. Yeah, as we discussed in the past, Jane, I totally support your point that neglect and financial hardship, we need to be clear that financial hardship doesn't equal neglect, and that's the point really. That there is correlation in terms of demand for social care services with more deprived areas of the city, but it will be wrong to say that families struggling financially automatically results in them being on the social care radar. So yeah, totally support that point. And yeah, we'll update in the next report and between now and then on the impacts of the trauma-informed practice, which we are seeing benefits from, including linked to the work we're doing on signs of safety and the graded care profile too on neglect as well. And I'd certainly take away your point about training for specialisms, both in terms of safeguarding, but also more generically in children's services. And David, yeah, the latter item on looked after children, I'd certainly welcome your input on that, and certainly some more of that analysis on longitudinal trends. But I think a lot of what you said, David, you'll see some of that in the later item on a few slides I'm going to share, but certainly would endorse your comments around that. Thank you.
Thanks, Steve. Can the board note the report and the very important partnership work that is in place? Is that agreed? Yeah, thank you. Item 8 is the establishment of Liverpool Safeguarding Adults Board. That report's on pages 80 to 82 and provides information on the establishment of a Liverpool Safeguarding Adults Board to focus on local priorities instead of the current Merseyside Board. However, the Merseyside Safeguarding Adults Review Group will continue to meet and develop to maintain the links across the local authorities, particularly looking at thematics that go across all of those and to learn from each other's experiences around there. So Martin, do you want to speak on that and update?
Yes, thank you, Chair. I think as has just been outlined, it's just to say that over the last few years, what we have had is an arrangement across Seddon, Knowsley, the Wirral and Liverpool, and it's been referred to as the Merseyside Safeguarding Board. In Liverpool, we've had our own safeguarding group. In addition to that, we not long ago had a peer challenge, which came to have a look at our safeguarding arrangements. And one of the overarching issues that was raised was a need to strengthen across each of those local authorities their local safeguarding arrangements and ownership, which I think does fit very well with the idea, with the proposals around place. On the back of that, the agreement across the authorities was to reshape the current Merseyside arrangement and make sure that we have clarity of ownership and governance around safeguarding in each of those local authorities. So we are developing a safeguarding board for Liverpool, but we will, as the chair has said, still retain some shared learning, particularly around safeguarding reviews, and work as a good practice group across both the current Merseyside board arrangements, but also include at least St Helens and potentially Halton. And we're also having a conversation with Cheshire around that. The plan is basically for the current arrangements would cease at the end of June, but we're looking to get our board arrangements in place from April. So.
Thanks, Martin. Any questions? I see Jane and David have got their hands up, they from before. Yeah, thank you. Any questions on that? No. So if the recommendations set out in the report agreed by everybody? Yeah, thank you.
Great.
Next, we've got the draft public health annual report. That's pages 83 to 125, and that's a preview of the document, which concentrates on the impact of the pandemic and the system response, with Liverpool leading on the mass asymptomatic testing pilot, the support provided to our communities, especially our most vulnerable residents. As well, the report also looks ahead with vaccination rollout and ongoing testing being a key part of our recovery as a city. Matt, do you want to speak to the report?
Thank you, Chair. So every year the Director of Public Health has to produce a Public Health Annual Report which reflects on key health challenges in the area and comes up with a series of recommendations. There's obviously no mistaking what the key health challenge we've all faced this year would be, so our annual report focuses on our COVID journey over the last 12 months during 2020. We've been fortunate to have had Sophie Baird with us this year and indeed for the next year. Sophie's a public health registrar within the public health team, and Sophie has led on the development of this year's annual report. So if you're okay with this, Chair, I'll hand over to Sophie, who'll give a very quick overview of the annual report. Thank you.
Thanks, Matt. Sophie?
Thank you, Chair. So we've been working hard since Christmas to get this report ready for year end. As Matt says, it's about the COVID-19 journey during 2020. It aims to tell the whole city's story, so not just the council, but our partners and our communities as well. And we're really focusing on that partnership working and the community-led responses that have taken place in the last year. The report highlights the impacts of the pandemic, both good and bad, and the actions that we've taken to support response and recovery. It also highlights that there are positives and opportunities to have come out of this that we need to harness moving forwards. It also recognises that while vaccination is giving us a route out of the pandemic, we also still need to be aware that there's more to be done. The report will be an online interactive report, and it should be compatible with screen readers for people who have accessibility issues, and we're aiming to have it finalised by the end of this week. We're aiming to soft launch it with partners next week and then hard launch it at the council's commemoration event for the first anniversary of lockdown. Later in the year, the report will relaunch with a citywide exhibition, which we've called Visible Virals. There's a lot more work to do on that, but we're working with culture on that. We've had input from a really wide range of partners on this report, including many of the organisations that are represented here today. If you have any further comments on the report, I would ask if you please try and get them to us by the end of today so that we can keep to our timescales. Take particular note of the recommendations on page 123 of the report pack. These are framed around our continuing response to this pandemic, lessons learned for the next pandemic, and partnership actions for recovery and further ahead.
Thanks, Sophie. Jane, and then Richard.
Thanks, Sophie. I mean, this is huge, this report, because not only have we had the pandemic, but we've had 10 years of austerity, but it's, I mean, not necessarily for minuting, but it is much, much better than the one that we had last year. So thanks to Matt and thanks for Sophie for that, because it's a very difficult one to do as well, because it's completely cross-cutting right the way through the council. I think what will be helpful is to somehow have a show how it links back into the city plan. I've noticed that unless I've missed this, Sophie, there isn't any link up that's clear enough for me anyway, in terms of, again, the Marmot report and the recommendations. That would be really helpful to do, and then back into the sustainable development goals. Just very quickly, some highlights. The education bit, I think it would be worth putting something in there about digital exclusion. That's been huge across the city and has been very, very difficult for children to deal with and for staff at schools to deal with. We've done some interesting stuff in Everton if you want to pick that up. And Vodafone have done 330,000 free SIMs across the country that some of our schools linked up to based on what we were doing in Everton. In terms of the where is it? The bit that when you put a big thing in about Michael Parkinson, to be honest with you, I just take that out and put Michael Marmot. I mean, I like Michael Parkinson, but to be honest with you, just put Michael Marmot in there, get the Fair Society Healthy Lives in there, and have that as the chapter. Have a footnote about what Michael Parkinson says if you want to. That's fine. In terms of Resilient City and the community shop, I know Martin Farran was involved in this. Unfortunately, they've got to be taught how to link this up because they didn't put real living wage in there. So they were having a community shop for people in poverty to be able to go in that was slightly labelling, to put it mildly. But they didn't, when they had the jobs there, they weren't even on a real living wage. There's been loads of other things that across the city that we might be able to pick up later because there's too much to put in almost. In terms of the other achievements, partnership working, here we are, community-led responses. On that page, Sophie, there's a lot more than fan support and food banks and Liverpool 6 Community Centre. I mean, there's huge amounts gone on right across the city on that. So I think it'd be almost better not to put that in than leave it in and say there's been a network of projects right across the city that work together and the principles on which they've been bounded. And then finally is the link up with purpose-led business based on principles that actually link up with all of that Marmot stuff, all back into the SDGs, back into the city plan particularly, that we can link up as a way forward as well. Thanks a lot.
Thanks, Jane. Richard?
It's a bit hard to follow in the format we've got it now, but this looks to be an absolutely excellent report. And on that basis, I'd like to think we're going to do more with it than just use it in Liverpool. Following on what we were saying before about the STP-ISC stuff, I think that you ought to be sending this to appropriate ministers and front benches, because you can really feel the problems of inequality coming out of this, and therefore what the public health challenges really are. So we need to get it out there. The annual public health conference is taking place the week after next, if I recall properly. I can get it out if it's ready in that time to all the delegates for that. And I'm actually chairing the last session with a minister, and I certainly want to draw reference and be able to give details of how to get hold of this. But a first-class report gave me a lot of information across the history, and we should be aware of our history, and I want to see this report widely used.
Thanks, Richard. And again, I think it's something that can link into the city plan as well, because lots of those areas are covered within that. And certainly, I think we also need to link it to our budget this year as well in the council, because what we did do in relation to our recovery plan was link that to a number of those issues that were highlighted across the last 12 months, but we already knew were issues across the city, particularly in relation to mental health, not just children's mental health, but mental health as a whole, domestic violence, digital exclusion. I know that was mentioned by Jane in the report, but certainly, work we intend to do in and around that. And just on that, those communities, and I would echo what Jane said, there was a whole range of community activity, down to even COVID funding that was given to ward councillors so they could directly respond to, emerging issues immediately within those wards. So lots of stuff, I think, that can add to that, but I would agree with Richard as well. This document is excellent and does need to go out there for wider recognition, not just of how good the report is, but actually what has gone on in the city through our partnerships and how strong those partnerships are, and the real partnerships, not just in name only. People have, and that bodes well with the changes coming in, particularly with the place-based stuff, in a sense of certainly being able to push our ideas forward through that agenda by using reports, I think, like this going forward. I've got David, Matt and Paul. so far in that order.
Yeah, nice one, Sophie. I was going to agree with Jane again in the Marmot fan club that I thought the it's a really difficult story to pitch, but perhaps the most important bit is the recommendation section, and I think there are lots of recommendations across collected inequalities reports and levelling up reports, some of which we've been involved with, that could be summarised somewhere and made Liverpool more Liverpool centric. So that's I'll send you some of those, but I just thought you could reflect some of those recommendations that are coming across strongly in national reports that aren't already captured.
Matt?
Chair, I'm happy to wait until after Councillor Brown's comments.
Yeah, sure. Paul?
Thank you, Chair. I'll have to be nice about Matt, and I won't say this as he comes after me. I do genuinely want to say a big thank you to all the public health team. This has been one hell of a year, and the way in which they have all collectively risen to the challenge presented by COVID, I think, does the City Council, the City, but also particularly the public health team, a huge service and a huge credit to them already. I think rightly, we have now seen public health put back at front and centre in the delivery of public health, public services, and I hope that I know that we as a council will continue to make sure that we have health in all policies as part of our decision-making process and as part of the city plan. And if Professor Michael Parkinson is watching, I'll give him my address for the Christmas cards that you'll no longer be sending to Councillor Corbett as a result of her commentary.
Thanks, Paul. I'll bring in Jamie then to strike another point, and then I'll bring Matt and Sophie back to respond to some of the points that are being made. Jane?
Oh, sorry, Wendy. Okay, so just a quick one in terms of, it might be worth adding in, Sophie, going back to what Matt was saying about we've got a very strong system in place for being able to support people to go to work if they need to go to work rather than be having to stay at home. Although the government took ages to give us to confirm that they were going to give us the discretionary payments for that. It would be worth putting in a note about the citizen support scheme that we've been running for years and the impact of that, plus the top up of the discretionary housing payment that we do to stop people being evicted and getting into debt, and on that council tax support as well, and then something around the way that we're using the basic needs list that the Poverty Action Group uses as a basis to make sure that people have healthy lives or attempt to have healthy lives. Thanks a lot.
Thanks, Shane. Matt?
Thank you, Chair. That was a really helpful conversation and discussion. Thank you very much. The one thing it's illustrated to me is, although we've absolutely tried to put our focus rightly, I think, on the partnership, on the city response to COVID, the conversation has given us a hell of a lot more examples than we've already captured, which I think shows the strength of the partnership response. What I would say is that it's not possible for the annual report to capture every single example. So what we will do is I'll work with Sophie to make sure we make reference to the fact that these are some of the examples, but there are much more. I think the point about inequalities in Marmot is well made, and we'll look to see how we can update the recommendations accordingly. And I would just like to pay tribute to Sophie for her hard work in pulling the report together, because it is, in my view, a very good report, very comprehensive, and sums up the fantastic response the city has given to the pandemic. Thank you.
Thanks, Matt. I would say it's an excellent report rather than a very good one. Well done, Sophie. And I think it is important that public health is seen in this way, in around that it's everybody's responsibility, all of our stakeholders in the city, not just those who work, within health or local government, and that it's about everything that we do, as a city going forward to promote, equality and fairness in all of our communities. So I think, reports like this really highlight those areas, not that we just need to focus on, but areas where we're doing well as partnerships, and that if we were given, some adequate funding, some more resources to do further research, etc., how we can improve on that further. So fantastic work, particularly given all you're having to deal with, and having done this, from December onwards, it's been excellent. So can we note the draft report? And obviously, I know Sophie's going to take into account everything that's been said today. Unless there's anything you wanted to add yourself, Sophie?
No, just as Matt said, it's trying to get that balance of detail and brevity. So we'll have a think about how we can include all of those things. Thank you.
Thanks, Sophie. So can we agree that the report is noted? Yeah, draft report. Thanks. Steve, the next item is the Looked After Children's Partnership work, which Steve is going to do a short presentation to us on.
Great, thank you, Chair, and Peter's kindly agreed to put the slides up for us. So, and just thank you for having this time on the agenda for this issue as well. Before I start, just to say something really positive, both in the public health report and in a session across Merseyside with some senior officers. You know, one of the few positive things about the last horrible year and a half has been the way people have come together and just really tackle problems together really positively. But one observation in the session on Monday is that we had some pretty big challenges before COVID came along. And I think one of the things we need to reflect on is how do we work together to tackle something like COVID? And can we turn our attention to some of the things we were struggling with before in a similar way? So I guess that I say that because I think what's really behind this presentation is I need your help. We need your help on this. So I'm going to talk very quickly just through some of the key issues around demands for social care services and volume of looked after children. And I hope just remind us all that it is a partnership problem and the impact that we're seeing for our city is significant. So the first slide is really just a reminder about the national issues. This is the National Safeguarding Pressures Analysis, which shows some trends in terms of Liverpool, child protection and children in care volumes, the Northwest and also nationally. And some of the things from the national analysis refers to things like children coming into the radar of social care services not previously known, the fact that we've seen a trend that universal services not identifying families soon enough in trouble. So that, for instance, this is a national issue, police being the biggest source of referral. And I guess what we're saying there is why are we referring a family in when the police kick the door in, when actually the previous 3 months, lots of agency staff have been in and out of that house, is the challenge there. The funding is an issue, and a lot of the early help and early help prevention work is based on some of the fixed term funding money. So that's an issue. And again, just to stress, it's a national issue. And then the number of children coming into care is rising. And some of the things we've touched on already today, parental mental health, domestic abuse, substance misuse are big issues for us there. Go to the next slide. So in Liverpool, here's some of our numbers very quickly. 15,000 contacts, 6,000 referrals, 1,600 children in need assessments, nearly 600 child protection plans, and over 1,500 children who are in our care, which is up 6.5% since the previous year. Thank you, Peter. In terms of not the sort of longitudinal pattern, I think David will be able to talk about, but the short-term longitudinal pattern, you can see the rise in children on the child protection plan, and you can see their neglect, emotional abuse and domestic abuse are some of the key drivers there. So that's child protection plan. The next slide is children in care. So we can see the trend there from February to now has risen up to 1,500. And the Northwest analysis was produced recently. And in terms of rates of looked after children versus the child population, Liverpool is second only to Blackpool. And we know there's unique particular issues in Blackpool. So there's a significant demand in terms of numbers of looked after children. If we look at the next slide, which is the human cost. So the top left there is about repeat removal. So this is women in Liverpool, 120 mothers having repeat removals. That's 415 children over that 20-year period. So I might, and the analysis of some of the wider city region by an organisation called Pause has shown that some women are on their 12th and 13th removed child. So just think about that for a second. 10% of the children in care in Liverpool have also been in also been a child in care themselves. When we look at things like educational attainment for looked after children, it's not as good. The percentage of the prison population that's been in care, the percentage of the homeless population, and care leavers being four or five times more likely to self-harm. Now, that's not to say that when children are looked after in the city, that council and partner agencies don't work incredibly hard. But this is the reality, that being in care, your life chances aren't as good. You know, that is the reality. If we move on to financial costs then, so just as one example of a financial cost of that, the planned spend for children's social care around the cohort we're talking about was 87 million. Our forecasted actual spend is more like 96. And some of the people on this meeting will know some of these figures, but just to remind you, in terms of a residential placement for a child, the average cost is over £4,000 a week. Now, I flag this up not to say this is a financial issue. It's not. It's a moral, ethical issue about numbers of looked after children. But the financial impact on all agencies across the city, from families failing and people becoming looked after in our care, is significant. And I flag it up also because I imagine what we could do with, for instance, that 147 children, average 4,000 a week, is £31 million. If we as a partnership, as part of the city plan, said, what do you think we could do? What amount of good could we do as a city with £31 million? I'm sure we'd all come up with some pretty good ideas. If we move on to the next slide, which is what we are doing. So across the city, again, council and partner agencies are doing some great work. There's some great work going on around early help and prevention, and there's some really good universal offers to help families in our city. Some more recent developments, and I won't go through all of them, but using troubled families money, contribution from the council and contribution from partners, there's a range of projects. So I'll pick one out, for instance. The adolescence team is funded by the council, got staff on there from the NHS and police. They've worked with 100 adolescents and their families since September, and only I think 2 of those have actually ended up in care. So when we focus, we can really make an impact. So I go on to the final slide, which is really the partnership response to this. So what we need to do, we need to improve our early identification and response to emerging issues, particularly neglect as one of the large drivers. We do need more of a focus on Think Family and commission services around family, and particularly these main drivers of parental mental health, substance misuse and domestic abuse. We do need it to strengthen our commitment and involvement at the non-statutory level. So we all need to focus at the right end of the demand here. And we do need to strengthen frontline professional curiosity. What is the child's day-to-day lived experience like? And what is the voice of the child telling us? And I guess my question to myself and all of us as a partnership is, what are we going to do differently around this? Over to you.
Thanks, Steve. Thanks, Janet. You were on mute, Janet, I think.
Yeah, no,
thanks.
Struggling to unmute. Thanks, that's a really interesting presentation. I think 2 things kind of strike me when listening to it. And one is the issue of care leavers. I think one of the most poignant meetings I have had while at the CCG was with a care leaver who was actually the same age as one of my sons, and the idea was just, you know, kind of having to fend for himself and navigate his way through kind of all kinds of issues, but also I suppose the link with health. I mean, you've highlighted the specific health needs that care leavers have, and I'm not convinced that that we are cited enough in primary care about who the care leavers are on our books. I think that has changed recently. I've recently kind of noticed that we've had kind of communications around that somebody who's joining our services is a care leaver, and I think that that we need to think about a joined up response to that, because there is no kind of guidance about kind of what type of services we should be offering. The other issue is that I think primary care in particular links up very well with school children with health visitors to look at our at-risk children, but there is a real gap or patchy provision in terms of links with school-age children and primary care to review those issues, because at that stage the school nursing service takes them over and the links just aren't there. So it's kind of thinking about how we can strengthen links between primary care and the school nursing service.
Thanks, Janet. Jane?
Thanks, Wendy. Thanks for that, Steve. That was really helpful, because looking at the analysis, particularly the human cost page, was useful to see how it was panning out and where there's repeats of deep-seated issues. I'm wondering whether the trauma-informed social work practice is being shared with adults as well. So as there's a link between both children and adults, would be interesting to see, because as the children become adults, that obviously would link up. In terms of the percentage increases with Liverpool compared to national, it's just eye-watering, really. It'd be worth. I remember when I was counting for Education Children's Services, Ofsted came in. I think he was looking at adoption or something, and we had a meeting with them. And I remember saying to them, "Look, and that was 2012 from memory." And we raised with them then, I was really specific with them, if you really cut the money back, this is going to unravel. You have to tell your bosses. And they were quite shocked at that stage, and that was 2012. But if you look back to the figures, I think from memory, we were just over 800 children in care in about 2011, possibly 12. But it'd be worth looking back at those and showing those back to government. And in terms of, again, you've got your issue of neglect coming up there as a big driver. I'd be really interested to see how that breaks down. And then lastly, the double whammy of austerity and COVID working together, and that toxic mix on top of all the other toxic mixes that we've got. Thanks.
Thanks, Jane. David?
Hi, Steve. Yeah, I think the numbers are really disturbing, and I see children being taken into care. It's a bit like infant mortality or maternal mortality. It's a sensitive indicator of something challenging across the whole system, and I think the inequalities aspect of this, people have said, hasn't been focused on to the extent of things like troubled families narratives. So the kind of individualization of these problems in specific families and family behavior, as opposed to looking at the structural factors that impact family functioning, especially family poverty, things like that. There's lots of literature, and we've been doing a lot of work on that I'd be happy to share at some point. But and also it links to the funding issues. We see as more children go into care across the country, the spend on children in care obviously increases proportionate to need, and the spend on services that protect children from going into care diminishes. And that's a microcosm of the problem that we're facing across different aspects of local government funding.
Thanks, David. Tony?
Yeah, just really, really interesting discussion and a very, very difficult set of circumstances, and just supporting what David was saying there. And I think it's back to what we do in terms of our place-based plans, how we take our models of provision forward in the future. I'm really keen on developing much, much stronger neighbourhood levels. I'm not an expert on child protection, but everything I've learned through my career in local government and time working with social workers is that you have to get the support right for the child, for the family, and for the community to create the right conditions for children to succeed. And of course, inequality and a whole host of other things exacerbate issues and undermine the ability at all of those levels for people to succeed, to take control of their own lives, which is what the city plan is all about trying to turn around. And as we put the city plan together, one of the really key discussions we had, a really frank discussion across all of the partners, was that if we're not prepared to come out of our silos and do this radically differently, then people like us in 20 years' time will have exactly the same conversation about the next generation, the same families with the same issues in the same communities, because the model of siloed paternalism is not tackling these inequality issues. And that's why, for me, that neighbourhood model, joining services up at a local level and putting local people at the heart of that process and seeking to empower them to take control of their lives, is a thing that will really will make a difference. The ability to share data and plan and prevent, because of that proximity to the families in those communities, I think will also make a difference. And back absolutely to the need for us to bring forward our place-based plans as quickly as possible.
Thanks, Jane.
Thanks, Wendy. I quite agree with Tony about the place-based process and looking at it in neighbourhoods. I think the one of the big key issues is that people have been trying to take control of their lives for a very long time, and there's a lot of stuff that we're doing that actually stopping them doing that, rather than them not wanting to do it. And one of the things that happens is you get a very quick turnover in neighbourhoods and communities, particularly in the most disadvantaged communities that have had it bad for years and generations, where as soon as the trust builds up between people that are working within that neighbourhood, they get moved on. And that trust then has to start all over again. And sometimes it's every 2 years. And it's totally exhausting, whether it's the likes of me as a local resident working as a volunteer or as a counsellor, but the families themselves, there's such fear out there still that children will be taken away if they're dead up front about what's really happening. And also that they feel that they're not being understood and listened to in terms of the big systemic changes that we've got to put in place. So I welcome that idea of focusing it, as Tony said, right down on the neighbourhood level, and also getting everybody to work together. Cut out the silos. Silos should be a thing of, we're not allowed to use the term, because where it works well is right on the ground. Then it splits out and then it comes back together again at the so-called top. So if we can try and change all of that round, that'd be brilliant. Thanks very much.
Thanks, Jane. And I think from one of the slides when Steve was saying, where they've done that focused work with those young people, in respect of them working, sort of as a team, addressing those needs on the ground with those young people and their families. The fact only one of them, up to this point has needed the intervention of actually having to come into care, shows. And I think it's looking at some of those. And again, I think, it was mentioned earlier, too much of the money is at the high end, when actually by the time, and I know Steve mentioned it, by the time a child is coming into the system at a child protection stage, they're virtually at that stage where it's almost in court. It's not even at that lower end. So as those services are squeezed, over time, then, actually you can see why families don't have that trust, because actually the experience in that community is once that statutory involvement becomes involved, it escalates very, very quickly. So it's that, and it is, and particularly in relation to domestic abuse. And I know we've been having a lot of discussions about this, and that really is where agencies need to join up, because particularly for children and for the victims of that abuse, largely women, but sometimes can be men as well, sort of they're doubly punished quite often, the victims, and then having to move out of your community quite often to move out of your city because there's no resources available, the trauma, those adverse childhood experiences, that disruption in their education, all of these things, and no recognition sometimes that families will want to stay together, and how do we work to overcome some of those problems. So people are coming up with the issues because they think, if I say I'm still with my partner, my children are going to be removed, or people won't work with me if I say I'm still in that relationship. So it's about us, actually being realistic in relation to how people are leading their lives and trying to encourage more healthy relationships, and actually supporting families to do that. So I think there is a lot to be done. I think, Steve, as you say, it is about everybody taking ownership. They are our children, corporately. But, apart from that, they're our city's future, and we do need to sort of really commit to this going forward. So I'm sure people will note that presentation, but I think it's important for us to look at some actions that the board can help take on board with that, Steve, rather than it just be a report mechanism. I know David said to do some work, obviously, around sort of some of those longitudinal studies, and research that's been done, but Tony will say if anyone for actions, what actions are people going to take going forward to help this, rather than it just be a reporting mechanism going forward. So thanks very much for that. Really useful. And I think those sort of things, Steve, should go to all select committees. If we're corporate parents, for each of our committees in the council, what are they doing to support? Sort of not just our looked after children, but to support children within our communities through that remit. It should be a cross-cutting theme around that.
Can I just chip in, Wendy? I'm wondering, Steve, I can see you put your hand up. I'm wondering whether, if the board agree, we should ask you and the partners working on this to come back with a specific set of asks in terms of the action that is going to make a difference.
Mm-hmm.
So rather than reporting, because we're all feeling, I'm talking about myself, we're all feeling pretty passionate about this now, but we'll all go and get on with our day jobs in about 20 minutes time and get sucked into loads of other things. And this is so important. I think it would be really good if we could come back with a very specific set of asks and actions that then as a board we can monitor progress against.
Yeah, that sounds good. Steve?
Just wanted to thank everybody for obviously the time on this and how clearly how people feel it's important, and absolutely support you, Wendy and Tony. Needs to turn into action. I think there's very clear, as Tony and others have said, within the city plan that the causal factors that are linked to this will all be in the city plan, and importantly, as Tony said, in the place-based plans, working with families and communities. I wonder whether if colleagues on the board would feel appropriate if myself and one of our assistant directors visited the senior management teams of our partner agencies on this board and just did this input and then reflected on those key actions with each organisation and bring it together.
Yeah, sounds good, Steve.
So I'm sort of inviting myself to people's management meetings there. That's all right.
Push yourself forward, Steve. Go on. Don't be a wallflower. Don't tell them any jokes. Don't let them tell any jokes anymore. Don't invite him on a Friday. He always tells jokes on a Friday, and they're very bad dad jokes. Right. Item 11 is the formal request to suspend the refresh of the pharmaceutical needs assessment. And that's on pages 126 to 129. In the earlier item on the draft public health annual report, it did show how public health is at the heart of the system response to the pandemic and support for our communities. And this report asks the board to consider supporting the submission of a letter from the Director of Public Health to NHS England, formally requesting a suspension of the refresh of the pharmaceutical needs assessment in order to be able to analysts to continue work on this response. Can I ask Matt to speak to this, please?
Thank you, Chair. Very briefly, we have a requirement as a Health and Wellbeing Board to produce pharmaceutical needs assessments. They're on a 3-year life cycle. Our current P&A expires at the end of this month. In May 2020, DHSE gave permission for the requirement for Health and Wellbeing Boards to publish a P&A to be suspended for a year, but obviously that doesn't cover us with our timescales. There is quite a lot of work involved in producing the pharmaceutical needs assessments, and obviously if this requirement is not suspended for this coming year, it would mean we would have to divert a considerable amount of resources, particularly from the public health analytical function, away from the ongoing COVID response and recovery elements. As part of the process, there's survey work to be done, there's analysis work to be done, and there's a mandatory 60-day public consultation period as well. There's an indicative timescale in the back of the report just to show the amount of work that's involved. So I'm asking for support from the Health and Wellbeing Board for us to request a suspension or deferment for another year. Thank you.
Thanks, Matt. I've got Sarah and then Richard.
Yeah, I completely support that proposal. There's a huge amount of work involved in doing it, and we don't get the public complaining to us about our shortage of pharmacy provision. We get feedback about just about every other part of health and social care, but I've yet to have somebody say I can't get to a pharmacy or their opening hours are too short. So I really don't think it's a priority for us. And if it's possible to get it suspended, I think that'll be very helpful for our overall COVID effort.
Thanks, Sarah. Richard?
I believe we should declare the report as well, but two things about the consequences of that. One negative, does that mean at a time when people like Boots, who are the biggest provider, Boots Alliance, are trying to cut 20% of their outlets, that this will give an outdated set of statistics, which means that they can just run riot through Liverpool? I mean, they've already closed 2 on Allerton Road. As an example, I know they've closed them on County Road. And the second thing is to go back to the COVID and the neighbourhood. If I remember correctly, the pharmaceutical needs assessment is a very structured document which doesn't necessarily show the importance of community-based pharmacy in particular that I would want to give it to. So is it possible to, in putting that report together in a new way, to bring in the neighbourhood nature of a community-based pharmacy, and in the context of what we've learned through COVID, what else could they be doing in terms of the public health agenda, including vaccinations, including flu jabs and things like that? But I just believe that the location, in many cases on the high street, means that they could be a much more effective neighbourhood tool for us than they're allowed to be at the moment.
Thanks, Richard. Can't see any other hands. Matt, do you want to come back to those 2 points?
Yeah, so there's 2 bits on that. So unfortunately, the pharmaceutical needs assessment is a statutory document in a statutory format. It's laid out in the way that you have to respond to it. So there isn't much scope, as I understand it, to change what we put in the assessment. However, Richard, I think it's a really good point that as part of our request to defer the P&A, we could also ask for the guidance around P&As to be updated to reflect the changing context, particularly in relation to response to COVID. So we could put something like that in there. The first point Councillor Kemp raised is correct, that it does mean that assessments against pharmacy provision will be outdated, and so there is that I guess there is a risk there of pharmacies changing their current provision based on a historical assessment of need, but it's 3 years ago.
Okay, thanks, Matt. Is the recommendation to support the submission of a letter agreed then by the board? Yeah, thank you. We've now got item 12, which is the subgroup updates. I'm going to take the updates from each of those groups and then open it up for questions. First of all is the Integrated Care Partnership Group. I know we've discussed this quite a bit before.
I think the main thing is you've given us the green light to move forward with the place-based proposals, to bring those back to Health and Wellbeing Board, and we'll crack on with that. I don't know whether Carol wanted to chip in with anything, but as far as I'm concerned, I think we know what we're doing, and we'll just get on with it.
Thanks, Carol.
Yeah, just to add to Tony's comments, we are mobilising the resources within the organisations. The strategy directors are coming together to do the detailed work around that proposal. So that is in progress.
Thanks, Carol. Matt, on the Health Protection Board.
So, Chair, the Health Protection Board continues to meet on a weekly basis. It's a subgroup of the Health and Wellbeing Board. We found it an extremely useful forum, particularly in response to COVID, to bring all the different elements and strands of that COVID response together. But we do bring the information to the Health and Wellbeing Board as well. So, for example, the epidemiological update we gave earlier. Just the one thing to note in the report is around variants under investigation and variants of concern. And there's a section in that update around around the current situation for us. Richard asked the question earlier about the Kent variant where it's 98%. So it's worth having a look at that, but otherwise, Chair, nothing else to add. Thank you.
Thank you. Carol, on the Joint Commissioning Group.
Yes, so the Joint Commissioning Group met on the 2nd of March. There's two parts to the agenda. The first is the business agenda, which is really about looking at the delivery of our existing joint commissioning programmes. We've got a single performance framework, so there's a real grip now on delivery. And then the second part is the developmental, which relates to the discussions we've had around the white paper proposals and the issues around place. So we are working on an integrated health and care business plan for 21-22, which is going to set out our integrated commissioning intentions, which are aligned to One Liverpool strategy. So the plan really is reflecting the direction of travel in relation to those white paper proposals and, affirming the principle of primacy of place and the direction of travel that is in the proposals about the integration of health and care commissioning at place. So the plan reflects our intentions to maximise the scope of that integration next year. We're taking a population health approach, so we're looking at 5 main population segments, and we're going through a prioritisation process at the moment. So we have a long list of commissioning proposals, but there are some uncertainties still. So certainly from an NHS perspective, we've not yet had the NHS planning guidance for 21-22. And we don't know what our financial allocations are. So we will need to prioritise further when we have that information. I suppose the other thing I would say is that, we're not out of COVID. So when we're looking at an integrated business plan, it's also about looking at our capacity. And there are uncertainties in the sense of some of the top-down things that might come at us around NHS recovery planning. We don't know what the vaccine programme will look like beyond the current programme. So will there be boosters? Will there be, second round of vaccine programmes in the year? And of course, COVID, we don't know yet what the course of COVID will look like. We're very optimistic, but we can't make any assumptions that we won't be dealing with further waves. So there are lots of uncertainties that we need to build into our plans and those assumptions really about being able to be flexible as we go through next year. But that plan is coming together and it'll be completed by May to go through CCG governance and council as well. So we will continue to update on that.
Thanks, Carol. And Jane, on the citywide strategy group for fairness and tackling poverty.
Thanks, Wendy. The citywide group hasn't met since we last met. However, the Poverty Action Group has been meeting on a regular basis. In the meantime, which has been really helpful, we've gone through each of the basic needs lists and seen how the difference that will make and the difference it's already making against each of the basic needs. In the meantime, I've met up with Jackie, the Chief Officer of Cheshire Merseyside Health and Care Partnership, with Devara Davies. Devara joined us from Canada, one of your team, and also the councillor lead from that. And I've also met up with people internally in the council, including Steve John Bauer, who does all the data analysis for you, which was brilliant, and Martin Thompson out of Tony's chief exec team as well, and others, again with Devara. I think so we're moving towards looking at how we can actually match the Marmot outcomes, the recommendations, against what we said before. How we can show that. So every time, the idea would be that every time we get a health and wellbeing board, we can see where we're up to with each of those 6 recommendations. Now that is good, and then that sits within the city plan. It's not an easy thing to do, and I can't do it on my own. Now David's obviously up with all of this, so I need to pick it back up with David on this one because it needs to sit very clearly within the city plan and gets fed through to the health and wellbeing board where the partners are, unless there's a different way of looking at the partnership. Who knows what's going to happen in May, but whatever happens, we've got to keep going on that whole Marmot framework, set against the city plan, set against the sustainable development goals, and then we're motoring then. Cheers.
Cheers. Thanks, Jane. Anybody got any questions of anyone from the working groups? No, well, thanks everybody for your reports back on them. It's really important that those subgroups, you know, as you say, are continuing to meet, but also feeding into the wider agenda. So that's it for this Health and Wellbeing Board. Can I thank everybody for attending, and for those who may be viewing online, and formally close this meeting.